Despite many important advances in cancer therapy, pancreatic cancer remains deadly unless it's detected at its earliest stages. To date, there's no proven method to effectively screen patients for pancreatic cancer.
A multidisciplinary research study among doctors at the Western Connecticut Health Network is designed to enable physicians to image and detect pancreatic cancer at early and hopefully curable stages.
Today, we'll focus on aspects of this study with a radiologist who was instrumental in developing the modified MRI procedure that may allow us to screen and image and potentially cure early pancreatic cancer.
So don't go away, we're up next. Hello, I'm Dr. Andrea Peterson.
And I'm Dr. Eric Mazer. Joining us to discuss a major pancreatic cancer research study from a radiological perspective is Dr. Ronald Lee. Dr. Lee is chairman of the Department of Radiology at Norwalk Hospital and an instrumental person in the study.
Welcome to the
Ron.
show.
Thank you.
I'm so glad to finally have you here. It's been such a long time.
I'm happy to be here.
So maybe start our viewers off a little bit about looking at the pancreas and what some of the challenges have been over time in trying to get good images of the pancreas to figure out what might be going on.
The pancreas is this retroperitoneal structure that sits deep in the abdomen.
It sort of sits behind all the intestines, behind all the guts.
Yep, behind the stomach. It sits on top of the spine and with bowel in front of it. And the bowel moves, and it's always difficult to see the internal structures. And so with radiology over time and technology, we've developed different modalities to image the pancreas. So
just to go back, in the old days, an X-ray, the old X-rays, you don't see the pancreas on an X-ray.
not at all. All that, the X-rays are just shadows, and it just goes right through the body. You just see a bunch of shadows, and you cannot see the pancreas at all because it's a soft tissue structure. So different modalities, different techniques have been developed over time. Ultrasound, CT, MRI are really the mainstays of imaging for us in the world of radiology. And with ultrasound, we can look at shadows using an ultrasound beam that has no radiation, but it just doesn't have the resolution or the ability to really look at the pancreas very well because there's all this bowel in front, and it just obscures what we're trying to see.
Yeah, I think a lot of people don't realize that air is the enemy of ultrasound, isn't it? Maybe you could just say a couple of words to that.
Yes, so air and just body density and increased girth makes it difficult for the ultrasound beam to interrogate into the abdomen. So being that the pancreas is so deep within the abdomen, it's just very difficult to see.
Now, why not just look from the back?
I was going to ask that.
Oh, well, sorry.
Good question. Well, there's muscle and there's spine back there, and so through the back, there's just no window at all to see the pancreas. And so ultrasound, while it's a good technique, it's good for looking at the ducts maybe or looking at the gallbladder. But short of that, it's much more difficult to really delve deeply into seeing the
So you can't really see
pancreas.
the details of the pancreas as well as you might like.
We can see the ducts, and we can see the gallbladder, and we can look for gallstones. But most times, the pancreas is obscured due to all of that air, and it just becomes difficult.
Yeah, I think a lot of people may not realize that these fancy modern imaging techniques have limitations and that we're not getting pictures like sitting across from the pancreas in a chair.
Correct.
That there are filters and things that get in the way.
Right. So then there's CT scanning, which is really the mainstay of imaging. It's fast, it's less expensive than some of the other techniques, but there's radiation that's involved. We may give oral contrast. Intravenous contrast is very helpful to light up the pancreas. And that is really the mainstay of the first screening approach to looking at the pancreas. So someone who presents with abdominal pain, generally the clinician would order a CT scan and we would image using a CT. But for pancreatic screening, we wanted to choose something that didn't have the disadvantage of having some radiation. So MRI would be the next technique. And the sensitivities, meaning the ability to detect disease, is about equivalent, maybe a little bit better with MRI imaging.
Really? Okay.
And the advantage of MRI is no radiation, but it uses a powerful magnet to image the internal structures. And so it really manipulates hydrogen in the body. And the body's made mostly of hydrogen because we're mostly water, H2O. So the magnet would perturb the hydrogen molecule, and we can get images out of that with a big RF antenna. and it would receive the signal back. And the great thing about that is no radiation. It's non-invasive. The only drawback to MRI is number one, there are implants and things that we can't scan. And number two, patients have to hold still for the examination, so it's a much longer examination. So the MRI examination would be about 30 minutes versus a CT, which takes minutes.
Yeah. Now, I just had an MRI, so I have some first of all, I can say, it's sort of amazing that it can do all those things to the molecules in your body, and you don't feel a thing. I mean, it's really amazing that things are happening to the electrons, and I don't understand all the physics of it, but that it is just so completely asymptomatic. But let me ask you, and again, this is just folks at home that might be interested, what makes so much noise? What there is banging and clanging and buzzing that's going off, and it's not. Here's this very sophisticated machine, and it sounds like a jalopy.
Right. So the physics is absolutely fascinating. Basically, you have a gigantic machine that's supercooled by liquid helium, and there are these wires that run around the magnet itself. And if you remember back to your old days of physics, when you run electricity through coils, it generates a big magnetic field. And the faster you move those electrons, the more powerful the field you can get. And so when you supercool it, those electrons move even quicker. And so to generate an image, what you're listening to are the gradient coils that are moving. And these gradient coils will generate a radio frequency pulse that goes into the body that then perturbs the hydrogen ions within the body. And you do not feel a thing. But you do hear this loud noise, and that's really what you're listening to. And then as a result, once these hydrogen ions are perturbed, they relax back to its native state, and then the RF antenna receives that signal back, and it generates an image.
It's absolutely amazing. And the quality of the images also can blow you away. I know we started with the brain, where we can see things in the brain we couldn't have hoped to see 25 years ago. It's amazing.
Absolutely. And everything began with the brain imaging because it doesn't move, whereas the abdomen does move. So the abdomen has always been a lot more challenging to image.
You mentioned something a couple minutes ago that I wanted to return to, also for kind of general interest. Maybe you can talk for just a brief minute about contrast in CT and MRI. Why is contrast sometimes helpful? What is it?
And what does it mean in the context of an MRI? Because, I mean, I understand stuff that blocks radiation. I don't really understand contrast when you're talking about excited hydrogen ions.
Let's talk about CT first and CT contrast. So for that study, we would inject a contrast agent through the vein, and it lights up the internal organs. It's really looking at just vascularity and perfusion.
The blood vessels. The
blood vessels and organs. So organs have blood vessels, and
so the contrast is in the blood, and the more blood that goes to the organ and the more flow, the whiter it appears on CT because it's blocking
because of more flow.
The medium.
And so abnormalities in the body will light up in a differential way from the native organ. So let's take pancreatic tumor. So the classic would be an adenocarcinoma, which usually lights up less brightly than the native pancreas. There are other tumors, neuroendocrine tumors, that are very, very vascular, so they light up even brighter. And so giving contrast is extremely helpful because it increases the conspicuity of lesions in the body.
So you might be able to see something that looks like it doesn't belong there, but also get a clue as to what it might be based
Absolutely.
on the contrast pattern that you're seeing.
Yes, and then I try to guess at the pathology before the pathologist actually gets a look at it.
And that's always sort of fun. I know but doctors have to have fun.
Yes, absolutely.
We like to challenge ourselves.
So for MRI, it's a different type of agent. It's something that's a gadolinium based. So gadolinium is a rare earth metal. It has 7 unpaired electrons. It's because of those unpaired electrons that the MRI antenna can picture that and receive that. So it's gadolinium bound to a carrier agent. It gets injected into the body, very small amount. And then likewise, it looks at the vascularity of the organs, vascularity of structures, and I'm looking at the differential between a tumor versus the native organ. And it's critical, actually, to give the contrast because it helps us to really pick up the lesion. Otherwise, it becomes that much more challenging.
But that's not part of this. Go ahead, ma'am.
I was just going to, so this is it's a wonderful discussion because I don't know that everybody knows how much science goes into these pictures that you wind up seeing and interpreting. And maybe you can take us from that science to the pictures and talk about participating in this new pancreatic cancer screening study, putting that together with looking for cancer that's affecting patients.
Absolutely. So in the previous segment, Dr. Frank had discussed trying to pick up pancreatic cancers. And so the goal is to catch it early. The earlier we catch it, the better we can intervene. Otherwise, the
Meaning
prognosis,
surgically remove it.
right. So the mainstay of therapy of pancreatic cancer is surgery. So we want to catch it in its surgical, in the earliest state, so that it's amenable to surgery.
And we should say that once pancreatic cancer has really sort of grown out of the pancreas or has metastasized to local lymph nodes or the liver, as much as you'd like to be able to grab all of that surgically, it means there are micrometastases elsewhere, and the patients become almost incurable, almost always incurable at that point.
Right, so the 5-year survival in general is pretty poor. So we're talking about 7% 5-year survival of all comers. If we can surgically intervene early enough, that survival rate jumps up at least 20% or more. So the key is to catch it early enough so that we can allow the surgeon to go in and resect the tumor. And so the purpose of this study is to be able to catch it at that early stage. And so there's a certain lead time and the doubling time of the tumor, and we want to catch it within that interval. So the purpose of the study is to scan the patient when they have new onset, for example, diabetes or family history or family risk of having pancreatic cancer, catching it in its earliest stage, and hopefully intervene early. And we're doing this at yearly intervals for at least 3 years.
So as part of the study, you're in that for at least 3 years.
Yes, so the goal is to monitor over 3 years and see if we can catch the disease and if MRI imaging will help.
Is it an MRI every year then?
Yes.
Well, let's bring up, we have a full page about the study. Can you remind us again which patients are eligible to participate in the study?
So new onset diabetics, there seems to be an increased risk with those patients. Patients who have had long-term diabetes but then had destabilization of the diabetes and a jump in the diabetes within the past year, or a family history, strong family history of
And
diabetes.
right now, patients over 50.
And those over 50, yes.
And they should call the number that was on the screen, and they can do that directly, but we prefer to work with their primary care physicians in doing this.
Absolutely.
And there's no, to reiterate, we discussed this earlier, there's no charge to the patients for this, and they will get their results.
Correct.
Ron, is this a specially designed MRI for this study?
Yes, so this study, in terms of protocoling this case, we've chosen to go with very high resolution and thin section images with a very high matrix, so that it's not your standard MRI.
So it's not a run-of-the-mill abdominal MRI. This is specifically looking at the pancreas with great detail.
Correct. So this is targeted with high resolution images.
And just 2 seconds, just to warn people, there can be false positives. And what does that mean?
Yes, so it's very common in the world of radiology when we're looking for a certain disease, we pick up many other things. And most of the times, those other things, those incidental findings mean nothing, and sometimes it does mean another disease process. So unfortunately, one of the drawbacks to any type of imaging study is the radiologist commonly will pick up other things. And then at that point, a discussion needs to be made with the primary care physician in terms of how to handle those, or those things to worry about or not.
Yeah, this is unfortunately what happens with screening, and it's always there's never a price. There's always a price to pay for everything. Unfortunately, I can go on forever, but we're out of time for now. We want to thank Dr. Ronald Lee, our wonderful guest, for joining us today. Come back again soon, Ron.
Absolutely.
Certainly, I would enjoy it.
Please send us your questions and comments. We'd love to hear from you.
And thanks for watching. Think about that pancreatic study if you know anyone who's eligible. Until next time, stay well.